everyone. Welcome back to the Healthy, Wealthy, and Smart YouTube channel. I am your host, Dr. Karen Litzy, physical therapist and owner of Karen Litzy Physical Therapy, a boutique practice in the heart of New York City. So before we get into this episode, don't forget to hit the subscribe button, the notification bell. You know how it works, so that you don't miss a new episode of the Healthy, Wealthy, and Smart podcast right here on YouTube. Now, for today's episode, I'm really excited because we are talking about blood pressure. And I know it may not sound like the most interesting of topics, but high blood pressure, heart disease, one of the number one killers in America. So I'm really happy for my guest to join us this week, Dr. Shah. Dr. Shah has 15 plus years of medical expertise and 11 plus years of leadership in the medical practices at city general hospitals to community settings to the Mayo Clinic. He has brought his expertise and experience to the Swiss startup Aktiia to change the paradigm of how the world's most common disease, hypertension, is understood and managed. Also an angel investor and advisor, he is passionate about applying technology to solve practical problems in medicine and believes strongly in the power of positive thinking and in collaboration. So I'm really happy that he came here to collaborate with the Healthy, Wealthy, and Smart podcast. So today we talk about a little bit about his pivot from the medical world to now being in more of the business world as the chief medical officer for Aktiia. We talk about blood pressure, about how to take blood pressure, what blood pressure means, what's good blood pressure, what's bad blood pressure. So it's a really informative podcast this week. I was taking a lot of notes. So if you are interested in keeping and staying healthy and having a good blood pressure and what that means, then this is the podcast for you. So everyone, enjoy today's episode, and I hope you have a pen and paper to take lots of notes. Enjoy, everyone. Hi, Dr. Shah. Welcome to the podcast. I'm happy to have you on, and I'm excited to talk about your non-traditional career path. But I think we'll still maybe sneak in some cardiology stuff as well, if that's okay by you. But thank you for coming on the podcast.
Sounds great, Karen. Thank you so much for having me. It's great to be here.
And so I have had some physical therapists on the podcast in the past talking about their non-clinical life, non-clinical career, whether it was full-time or part-time. So can you tell the listeners what was the pathway for you going from a full-time practicing clinician to a full-time non-clinical clinician?
Yeah, I think probably the best place to start to explain it really would be to start from the beginning. And I know, people can read about, sort of my training pathway and history and all that. But I think every step of my training and real practice was one step that was required to then pivot in some other way. And so I think sometimes we think about it as, okay, people are on this one track of clinical medicine and then they just turn right and they go a totally different way. And my personal belief is I don't think that's true. I think every step on our journey is crucial to make that turn possible. So for me, I grew up wanting to be a doctor. I went to medical school in Kansas City at the City General Hospital, which was great. And I loved it. And I learned really like deep, hands-on clinical medicine, putting in IVs, running pumps, they had chronically understaffed City General population. Great place to be a medical student. And then I went to residency at Massachusetts General Hospital, where I was a senior resident or junior resident next to someone who'd invented some molecules or started and ran an NGO in Africa for 5 years before coming to residency. So it really broadened my mind as to what you can really do in a medical career. And then I went to Washington University in St. Louis and had a 1,200 bed hospital, just in it in terms of serious, deep clinical training and really high level practice. And then after I finished my practice, I did something that at least my mentors thought I was completely bonkers for. I went out and started my own practice from scratch in Portland, Oregon. And I was literally with 2 EKG machines and an MA. That's it. And so, that's where I had to learn how to order equipment, how to do power levels, how to do cost benefit analysis, how to negotiate with Philips and GE for my echo machines, how to hire staff, how to manage people, the real business of running a practice, in addition to actually doing the practice, which I'm sure a lot of your listeners probably can, relate to. And it was a big transition for me coming from 2,000 bed organizations where everything was just there. All the infrastructure was just there for you. All you had to do was write the order and figure out what the next steps were in medical treatment. It's a huge transition to really running your own business and practice. And so I learned that, did that for 7 years. I ran the practice, this umbrella overall practice, for 5 years. And then I started, dabbling in other things. I kind of always had that somewhat of an entrepreneurial spirit. And so I started dabbling in other ways. So I started doing some angel investing. I was finally making enough money that I could take some and invest in small companies or invest in private companies or do some real estate investing, just small, nothing major. But it got the wheels turning. It got me thinking like, well, okay, what else can I do with, now that my practice is running stably and well and all these things, what else can I do? And then an opportunity came up kind of out of the blue to be at the Mayo Clinic, which is, I took that and really practiced in a very focused way in thoracic aortic diseases. But again, that was necessary in a different way, is that a lot of the opportunities that then came my way would have never come my way if I was in private practice in Portland, Oregon.
Right.
But there
to
I
have
was,
that Mayo Clinic attached to you is a big deal, right?
And same thing from Mass General. Like you are the same doctor, you're the same clinician that you were the day before, and now you're just doing it with a name on the wall, and all of a sudden opportunities come your way, offers come your way. So then what I did is I really started an exploration of what's possible as a clinician. I did informational interviewing hundreds of doctors. It took 7-8 months. But that was crucial also for me to learn, what does the chief medical officer for MasterCard do? I had no idea. I was like, wow, that sounds cool. Let me figure out what that person's doing. And I would just email these people, sort of cold calls, just, hey, you're a doctor, I'm a doctor. I see you're doing this something interesting. Would you talk for 15 minutes? And I was shocked. 95% of them would respond and say, yeah, happy to give you 15 minutes, because they had done it at some point in their career in the past. And so they're happy to sort of pass it on. And then one thing led to another, and I happened to find this opportunity with Aktiia, which is a Swiss startup. I didn't know them, but this was the process I went through. And it took that time, it took that work and energy and building on all that clinical experience so that when that opportunity came, I was ready, I was mentally prepared, and I had all this deep clinical experience that then was all of a sudden highly valuable in this very different way in a startup or in the business world. And so that's sort of the process that from start to finish in 5 minutes.
Yeah, perfect. And what did you learn from all those interviews of other physicians doing some non-clinical or non-traditional, we can call it, roles?
That my biggest takeaway was that I wish I had known about that world or all these different pathways earlier. And I think one of the consistent shortcomings of traditional training pathways is that they essentially, none of that is ever sort of highlighted. You never pay attention to it. Or mentors at these academic or training programs are academics. They're in that, in that lane, and they're clinicians. And even practicing in private practice can be a little bit of a taboo. So departing and going off into the corporate world is I think it's getting more acceptable now, but certainly as when I went through training, it wasn't. And so I think there was this just complete lack of understanding about what those worlds might entail, and complete sort of probably a bias that, why would you do that? You've trained all this time to be a clinician, or you've trained to be a physician. Why would you waste your skills doing something else? When in truth, it's not a waste at all. In fact, it's like in the corporate world, in business, and in all these companies, they are desperate for experienced clinicians, desperate. because they have no perspective in whatever they're doing, and that it relates to healthcare. They have no clinical perspective. They don't know what it is to treat people day in and day out. And there's nobody there sitting at the table with that perspective. So you walk in as an experienced clinician, 50% of the stuff you could immediately throw out and say, none of this stuff makes sense, what you're talking about. You should go down this other road. Or why didn't you think about that? This is very bad, but over here, this is a great solution that you found. And they're desperate for that. And that only comes from clinical experience.
Yeah. And, having worked in different clinical settings, and now working in a startup setting, what are the pros and cons, in your opinion, to when it comes to your well-being, right? Meaning, we hear a lot about burnout, certainly in the physical therapy community. And I'm sure since COVID, it is certainly there in the physician community. So when you're looking at all of these different settings, what are pros and cons for the well-being of the human, of the human being of the physician?
Yeah. I mean, 10% of the US physician workforce left the workforce last year.
Is that right?
And 10% the year before that. And it's not coming back.
Wow.
And we're not training, enough new graduates to fill those spots. So
oh my gosh,
we're in trouble as a field. So although I will say, for your listeners who practice clinical medicine, you're only going to be more and more desirable as the years go by. The likelihood of you ever not having a job, even without ChatGPT and all this AI stuff, unlikely.
Yes, ChatGPT is not going to replace a very, very skilled clinician. It's just not going to happen.
It is unlikely. So
yes. When because you've worked at all these different clinical settings, what is best for wellness of the physician?
Yeah. I mean, I think there are trade-offs, but this is my personal opinion. And coming from a physician standpoint and a cardiology standpoint, there's the primary trade-off, the benefit that I see, after having made this transition, is that, and because it is also a startup, so I'm not working for some major multinational conglomerate corporation, which might feel different. But in my world, at least on a small company or a startup type company, you at least for me, I have gotten the sense of autonomy back, of a sense that I am in control of my own schedule, and simple basic stuff like I can take my child to the doctor if I need to. No one's going to harass me about picking them up from school. It's just sort of what we imagine as sort of nuts and bolts type stuff. Nobody really asks. As long as you do your work, and as long as you're there when you're expected to be there and show up for the meetings and do and perform your duties, you're treated as an adult. You're given that leeway, given that freedom. And I think in medicine, that has, for a number of reasons, and there's not any one particular reason, it has really is really not the case. It's really a lot of systems and a lot of organizations. The physician is now the highest paid cog in the wheel, and you're a worker, and so be it. And physicians have in some cases, most of the cases, accepted that, that they've ceded control of the organization over time and in a lot of ways. So they've given control to an administrator who now generally is not a physician, and there's directing the physicians that you have to be here at this time, and you're gonna see this many patients, and you're gonna see them on this schedule, and you're gonna do this, and that's it. It's extremely dictated. And so I think that is one of the things I think is one of the biggest drivers for burnout, for lack, a sense of poor well-being. And I think also time is the other thing.
Yeah.
And time, this is also something that as a cardiologist, I think physicians, we do to ourselves. There is a lot of, everyone says time is money, right? That's a saying that's very common. And in the physician's world, and I'm sure in for a lot of your listeners, it's the truth. The more patients you see, the more therapies you do, the more you're able to build, the more you're able to, that's your income goes up, et cetera, et cetera. But it's a hamster wheel that the more successful you are, the harder it is to get off. And this is what I experienced in my private practice. This was the most apparent. I worked for 3 years. I started it from scratch. And at first I was working hard because I felt like sense I was doing something that was really impactful. I was building something, I was creating something, building a group, building a practice, building an organization, hiring people, getting people jobs, like all these things. It was really was very rewarding. And then after about 5 years, the practice ran itself. All I had to do was show up and do the work, see the patients, do the charts, and that's it. I didn't really have to think about much else. And it was very successful in terms of patient volumes. I mean, at the end of the 7 years, I had 8,000 patients. So the volumes were just like, it was just a continuous max speed hamster wheel from start to finish, morning to night. And about 5 years in, I was like, boy, this doesn't feel great. And I'd rather go home earlier. I'd rather not do this for as long as I'm doing it. So I made the conscious decision to pull back, to take at first a half day off a week, and then a full day off a week, and then cut my clinics to end at 3 p.m. so I could go home, and every day I was home by 4:30 or 5. And I didn't start till 9, so I could drop my kids at school. And to me, I felt much better about practicing because I had the time with my family. I had the time at home. I felt the other parts of my life were there. But, in truth, if your salary goes down, and I think for a lot of people, especially single income families, or if someone's by themselves, or if somebody has a partner that doesn't work and bringing in income necessarily, that's hard to do. That's hard. But if you're able to reduce that velocity on the hamster wheel, I think it opens up many other aspects of your life that a lot of us clinicians tend to ignore, tend to put aside. And I think that's where we see well-being, emotional well-being, social connection, hobbies. Those are some of the components for that well-being that generally are not always, I don't want to generalize, but a lot of times are ignored because of the demands of the practice. But it doesn't have to be that way.
Yeah.
I mean, we all could work 24 hours a day, 7 days a week. The work is always there, right?
Right.
I mean,
right.
always.
Yeah. There's always people to be seen, and wait lists to be had, and people with injuries, people with cardiac events. I mean,
you could just work all the time. The charting is never done. The patients are always there.
Right.
So it has to be a conscious choice from within to say, I'm going to choose to cut it off here and there. I'm going to choose my own schedule. I'm the master of my own destiny and the arbiter of my own well-being. But that's a conscious choice that we are not trained for. And it's not modeled generally by our seniors. And maybe it is going to happen now, more so in this coming generation, perhaps. And I hope so for them. But that's what I see.
Yeah, time will tell. And now you mentioned the startup that you're working with, Aktiia. Did I say that correctly?
That's right.
All right. And Aktiia is about monitoring blood pressure. So before we get into what the company does, let's talk about blood pressure. So give us a blood pressure 101, right? So, because there may be people listening who are not clinicians, who know that there's a top number and a bottom number, and that's all they know. And they don't want either one to go too high. But can you give us a 101 quick lesson on blood pressure?
Yeah. Okay, here goes. So the blood pressure refers to the pressure inside your major arteries. So the artery in your chest or the arteries in your arms, that's where we usually check blood pressure. And what we're actually measuring, when your heart squeezes and pumps out all the blood moves down the arteries. And at that time, when the blood is moving down the arteries, the pressure in those vessels goes up because there's more blood coming into those vessels. So they actually distend a little bit, the pressure goes up. And that peak pressure during that movement of the blood through the arteries that's generated by the heartbeat is the top number, or what's called the systolic blood pressure. The bottom number is in between heartbeats, that after that distension goes away, after that bolus of blood coming into that artery goes back to its normal state, in between heartbeats, there is a consistent pressure of that artery, and there is blood sitting in it, and there's a consistent pressure there. That pressure between the heartbeats is called the diastolic blood pressure, or that's what the number on the bottom is. It used to be talked about that one number was more important than the other number. The truth is, it's not really the case. They're both important. They're important for different reasons, but that's what blood pressure is, and that's where the numbers come from.
Right. And then what is considered normal blood pressure? So let's say for people 65 and younger, and then 65 and older.
So it actually doesn't have much to do with age. So if you look at the major guidelines which define these blood pressure thresholds, age actually has nothing to do with it. So normal or optimal levels of blood pressure is 120 on the top number over 80 on the bottom number, or below. This would be normal or optimal blood pressures. Sort of elevated but not high would be between 120 to 130, and between 80 to 84 generally. And then over 130 over 80 in the US, and in other countries it's slightly higher, but let's just say for the US listeners, 130 over 80 or above is considered high blood pressure. And there are grades of that, but bottom line is that's the threshold to consider high blood pressure.
And if someone, everyone's got a machine at home, and we'll talk a little bit more about Aktiia and what they're doing in that arena, but I shouldn't say everyone has the ability to have a machine at home now, right? So let's say you're taking your blood pressure every day, and one day it's really high, but every other day it's around that 120 over 80 or less. Is that the time to call a cardiologist? So the question is, when do you call a cardiologist? When do we start getting worried?
Yeah. So this gets to a broader question, which is, how do you know your blood pressure is high or normal? Or how do you know what your blood pressure is? Like you said, this is a very common example. Someone comes into my office and they say, Doc, my blood pressure was normal. I check it 3 days a week, and most of the time it's 123 over 82. But this one day it was 145 over 90. Should I worry about that? And the answer is, generally speaking, no. But there's a broader answer, and that is, what we really care about is, what is your blood pressure over time? So the primary risk of blood pressure isn't the number. It's just a number. That's not the risk of blood pressure. The primary risk of blood pressure is having an abnormally high blood pressure for over time, usually years, months, years, decades. That's where blood pressure does its damage. So the risk of blood pressure is time dependent. So 1 point in the day, 1 time, 1 day, 1 week, 1 month even of having abnormal blood pressures really doesn't make a big difference overall. What you really want to know is, what are my blood pressure ranges over weeks, months, years? And so to answer your question, no, 1 time reading of a high reading doesn't really matter. But here's the catch. Who actually measures their blood pressure multiple times a day, every single day, for weeks, months, and years, to actually understand what is their trends over time? And the answer is almost nobody. Even people with high blood pressure rarely check their blood pressure on a routine basis. And it has to do with the cumbersome nature of the cuff, and having to sit in a certain position and do all the things to take an accurate cuff measurement. And it's just a hassle. You have to interrupt your day and do these things. So the real idea is to get to a way to look at blood pressure easily, passively, automatically, without you having to do anything different, but gives you that longitudinal assessment of risk based on your blood pressure.
Yeah. And you had mentioned something there, you have to be in a certain position. Are there any do's or don'ts for when you're taking your blood pressure? So if someone at home is listening and they're like, well, I have this cuff and I was sitting and is there a certain position you want your arm to be in, your legs to be in, your
Yes.
body to be in? Go ahead.
Yes, there is, and it is, I'm going to tell you, and you're going to laugh because it's ridiculous. But all cuffs have only been validated for use in only one position and environment. It's not just position, it's the environment as well. And so I'll explain. So what you're supposed to do when you're supposed to take an accurate cuff reading is you're supposed to sit in a quiet room for 5 minutes before you do anything. Don't do anything. Your feet are supposed to be flat on the floor. Your back is supposed to be against a chair. Your arm is supposed to be roughly at heart level. You're not supposed to have eaten for the last 30 minutes, nor smoked, nor drank alcohol, nor exercised. You're not supposed to have loud noises or children. You're not supposed to talk. You're not supposed to listen to anyone talking. You're supposed to have an empty bladder, and you're supposed to have no clothing on the arm that you're taking the blood pressure measurement on. Now,
Okay,
that's the environment that all cuffs are supposed to be validated in, and they are only validated in that position and environment, and that's what the guidelines recommend. Now, ask yourself this question rhetorically. Is that the only position that we spend the majority of our lives in? Position and environment.
I'm going to say no.
Right. So is it the most appropriate way to assess blood pressure? That's our standard, is to look at our blood pressure only in that position? And of course the answer is no, but that's how historically cuffs have been validated. Therefore, it's just carried on and on and on now, because that's the primary tool that we have had to look at blood pressure. So that is a sort of fallacy about the historic development of blood pressure devices that has led us to this point. But that's how you're supposed to take an accurate blood pressure.
Okay, well, that's a lot. I didn't even realize it was don't talk to anyone, don't have someone talk to you. So it's like, no wonder when people go to the doctor, if they have to go to urgent care, the first thing they do is put the cuff on and the person's freaking out. And so then it's really high. And they're like, well, usually when I take it at home, it's like 120 over 80, but now it's 150 over 85. Like, what's going on? So I'm sure you saw that a lot in your own practice, especially if someone's going to see a cardiologist. They're probably already a little nervous.
I mean, the rates of what's called white coat hypertension, which is what you describe, which is when you're in an office sitting around and there's a white coat in front of you and you're nervous and you're sick and you're not feeling good and all this stuff, is about 30%, 30% of people. That's a lot of people.
That's a lot, yeah.
And so it muddies the water even further about who actually has high blood pressure, or do they just have white coat hypertension? And combine that with the fact that most people don't check their blood pressure at home, and to get those other readings to understand that their blood pressure. So it just gives a lot of confusion and and there's just a significant lack of data in blood pressure. As much as cuffs have been around for a long time, 110 years, 50 years in the way that they exist today, and medicines and blood pressure, research has been around a long time, we still don't do a great job at hypertension management. Just to give you a statistic, of all the people in the world who have hypertension, which is 1.4 billion, the control rates of high blood pressure are, wait for it, 20%. 1 in 5. That's the people who have their blood pressure under control. 20%.
20% of people with hypertension, or 20% of people in the world?
20% of people with hypertension.
Oh my.
Yeah.
Oh, that's low.
Very low. And in the US, it's 26%. So yay, US. But still, it's terrible.
That's terrible. So it's still so poorly managed.
Still poorly managed. And one of this, your questions are getting to one of these major gaps in hypertension management, which is a complete lack of data. We don't know what our blood pressure is at home. We don't know, most people don't measure it correctly. They don't measure it often. They don't measure it well. The office measurements are often erroneous. So many physicians, and me included, practice for years in hypertension, and still do, with almost no data. Titrating medicines, guessing at what your numbers are, we don't really know what's right. So we're maybe less inclined to up-titrate medications or less inclined to try something else because we're just guessing a lot of the time. So that's a huge gap in blood pressure and even in the awareness, just in people, without even going to a physician. About almost 50% of people who have hypertension are simply just not aware that they have it.
Right,
So,
absolutely. Until, God forbid, something
yeah,
happens.
correct. And even then, and then it's, essentially too late, right?
Right.
This, and that happened to me all the time. People would have a heart attack or need surgery. They'd come to see me and I would take care of whatever the urgent need was. And then they'd come back afterwards as a follow-up and they'd always ask me, Dr. Shah, why did this happen?
Of
And the
course.
answer almost always would be, well, it happened because of decades of untreated problems. Hypertension is the most common one, but diabetes, obesity, smoking,
Right.
all
Right.
kinds of other chronic diseases, but hypertension was by far the most common. And I said, we can't walk that back now. You're 65 years old, 70 years old. You can't go back and change that. The time to make a difference and to be proactive was when you were 30, when your
Right.
hypertension started,
Right.
which it does for a lot of people in their 30s. And they just don't know because they don't feel it and you don't check it. So,
Right. Oh my gosh. Well, then that brings us, as we were talking about data points and people not checking things. So that brings us to what you're doing at Aktiia and what the company is doing to solve this data problem and this not checking problem. So
right.
tell the listeners a little bit more about what the company's doing and what your role is there.
Yeah. So, sorry, my role is the chief medical officer. So I'm as we talked about earlier in our conversation, I'm the primary physician's voice, clinical voice in sort of all aspects of the company. And it's a great team. And what the founders have developed now almost over 20 years, although the company's been in existence for 5, but they've been developing this for 20 years in Switzerland, is a way to measure blood pressure using optical sensors placed on the wrist. And optical sensors are just a fancy term for what we all know in a lot of the wearables that have them now, which are the LED lights, the green LED lights, and an optical sensor sitting on your skin. And so it's a combination of this very simple wearable device, but the real sort of intellectual property and the meat of it is they take these waveforms that come from these sensors and they analyze them with these powerful algorithms that they've developed over 2 decades. And they are able to measure blood pressure using these signals. So it's something you can wear. It doesn't squeeze your arm. You don't have to be in a specific position. You just live your life. All you have to do is put it on. It looks like a simple bracelet. It's very, very easy to wear. And it'll give you 20 to 30 readings of blood pressure a day. It'll give you 800 a month, 200 a week. And all you have to do is wear it. You don't have to do anything else. And, so it really provides this tremendously rich data set of blood pressure and heart rate that then can be turned into insights. The simplest ones would be, what's your average blood pressure over the last week or month? What's your trend in the morning versus the evening? Those are simple things. That's the easy stuff. But then the bigger questions are, as we layer more around this core technology, what can we derive out of those complex data set? How can we start being more personalized? Why does one person's blood pressure pattern make them predisposed more to stroke, but if somebody else makes them more predisposed to heart failure, whereas the third person is heart attack and the fourth person is arrhythmia? We don't know those things. Right now, blood pressure management is just one size fits all. You come to me for high blood pressure, I'm going to give you the same treatment and same recommendations that the next person and the next person and the next person gets. It's very one size fits all most of the time with little variation. But it shouldn't be that way. We should be able to use this data set to really start personalizing both the insights from it and the recommendations for that person. And that's really what we're working on. That's the true, sort of transformative power of it.
And are they there at that point? Like, as the data that you're collecting, have you found any of those insights into patient care yet, or do you need more data?
The data is there. what we need now, and we have about 30,000 or so active users in Europe, and we have a number of clinicians and program organizations using it. What we need to do now is take those high, rich data sets and compare them to health outcomes data. So looking at medical charts and looking at different disease states and different outcomes and different medications, and then looking at what those patterns mean in the context of what we can measure and see in the traditional sense. That's what we're doing now. So the data is there. Now we have to go figure out what part of that data means what. And it's a puzzle, but that's where we're heading.
It's when that's when all the fun happens.
Yeah.
When you get to kind of put all this together and then be able to make recommendations based on the data you're getting from not the group as a whole, but bring that down to the individual person. And I will say it's not available in the US yet. Is that correct?
No, not yet. We're working with the FDA, but it's not available yet in the US. Unfortunately, it's still going to take time, but but it's available in Europe, and we're expanding access to multiple other countries as we speak. Yeah.
Perfect. So for our European audience, it's definitely something to check out.
Yes.
And where can people find out more information about Aktiia?
Right now, all of it's on our website. So just aktiia.com, aktia.com, and it has everything. It has how it works. It has what the device is. It has all our research behind it. It's all posted publicly. We want it to be very transparent, and you can order it online. So it's all there on the website.
And I guess, what is the ultimate vision and mission for the company?
So I would say there's two parts to that, but the primary one, the real guiding star, is we want to help 100 million people with hypertension be under better control. And as grand as that sounds, I think that is actually still too small. I think what we need to do, if you think about it in the context of everyone's experience with healthcare environment, it's a very reactive process, right? You go to a physician. You ask a bunch of questions, you get some labs, you ask about what's happened in the last 6 months or a year, and you get some regimen for the next 6 months or a year, and so come back in 6 months or a year and call me if you have a problem. It's extremely reactive. Cardiology is the best example that I can think of. Come to me when you have a heart attack. That's when people come to me. Okay, that's great. And we have great treatments for heart attack, surgeries, et cetera. That's all good. We really, obviously, those are transformative things. But why not talk about prevention now? Why not talk about how can we prevent some of these things from happening as much as we can? How can we lower people's risk? How can we be proactive in the gaps of time that are so much bigger than the office visits? 15 minutes once a year. What about the rest of the 365 days and 1,400 minutes that happens in between? How can we do to up-level somebody's activation and empowerment and knowledge in a way that's consistent for them? And so what we do is we kind of take our core technology and we wrap it with layers of other interactive features with the smartphone, so people can then start to interact with their data more frequently and become empowered and activated by the sort of expert knowledge that's at their fingertips, rather than only when they go to see a physician. So we want to supplement what you get from healthcare, not replace it. Supplement it, but make it available on your time, in your location, regardless of access to care, regardless of where you are in the world, be in rural India or downtown Manhattan, and get the same knowledge in the same way. And that's really what we're aiming to do, to sort of transform those major white spaces between episodes of care.
Education, right?
Yeah. In the end, right? I'm a cardiologist, and people come to me not for surgery. They don't come for procedures. What they come to us for, and to all your listeners and to you, is they come for our knowledge. That's what they come for. They come for our advice about what to do next. And then, yes, we help them do it. But they come for the knowledge. And so that is the true sort of captive power of the healthcare and all this expertise that we've gained through all this time and energy and efforts and study. We can make that more widely available to a lot more people if we use technology to do that.
Yeah. And I think that that is certainly the direction healthcare is going in. And as practitioners, I think it's incumbent upon us to kind of prep our patients and let them know that these things, some already exist, some are on the horizon, and this is how you can take control of your own self.
Absolutely.
And have a better understanding of maybe when the system isn't going right, instead
Right.
of, like you said, you're in your 30s.
Yeah.
I don't know.
Yeah.
I don't know
Right.
what's going on,
That's about right for me, at least. It's like I
right?
didn't go get checked out or anything.
I don't know. I feel fine. So instead of
Yeah.
that, hey, let's get a little more knowledge and a little more data to kind of help you move forward in a way that is
Right.
healthy and with longevity, and let
Exactly.
everyone live a long, healthy life.
That's
Um, well, I want to thank you for sharing your story from going from a highly involved clinical career to now in a non-clinical role, although, like I said before, just non-patient care role, because I would argue
right.
your role is still very much clinical. Um,
Yes.
where can people find more information about you if they have any questions? And again, just repeat that website for Aktiia.
Sure. So Aktia's website is aktia.com, aktia.com. We have all on all the social channels. We're at Aktia Global. And then you can find me on LinkedIn, and maybe in the show notes we can list the LinkedIn profile and everything, and
Perfect.
they can always hit me up there.
I will definitely do that. So that will be in the show notes, and you can get the show notes on any podcast platform that you're listening to. Those show notes are there. So before we end, I have one last question. It's one I ask everyone. And knowing where you are now in your life and career, what advice would you give to, let's say, your 20-year-old self? So I'm assuming in undergrad, 20? Yeah.
About.
Yeah.
I would say never stop challenging yourself and take more risk.
Mm.
My 40-year-old self is would you tell my 20-year-old self to be more risky, take more risk, do things that push you and challenge you in different ways. And because that I've only done that lately in my career, late in my not late because I'm not late, but later, and I wish I had done that sooner. And every time I did, and every time I really pushed the boundaries and got uncomfortable, I was always glad I did, in a way that often was unexpected. I didn't
Mm-hmm.
know what the result would be. I didn't know what the next step might be. But when I did it, and on the other side, even if it didn't work out, honestly, even if I failed at doing something, I tried and it didn't work, I was always glad that I tried. And I learned a lot from those experiences, a lot more, and people have said this before, a lot more than when it went well and when I had a
Mm-hmm.
success in an expected way. So that's the biggest message I would give to myself.
Yeah. Great advice. Take more risks, to a certain extent,
To a
but
certain extent.
I
Yeah.
love it. I think it's
Yeah.
great. Dr. Shah, thank you so much for coming on. Loved hearing about your career, and thank you so much for the BP 101. I really appreciate it.
Thank you so much for having me, Karen. I really appreciate it.
Anytime. And everyone, thanks so much for listening. Have a great couple of days and stay healthy, wealthy, and smart.